Sir, good to go, sir.
Yes.
Okay.
Please.
So,
start.
good evening, everyone, and welcome to today's ISOT CPC session. I am Dr. Jigar Shumali, Executive Council Member of ISOT and Program in charge for this CPC series. With me, Dr. Radhika Patel as a Program in charge is there. So, it's a pleasure to host this academic discussion on the important and often complex topic, and that is renal failure after liver transplantation. And we are fortunate to have the distinguished panel of experts with us today. Dr. Anirudh Datta is the senior resident at IPGMER and SSKM Hospital, Kolkata, who will be the presenting today's case. Dr. Pratik Das, sir, consulting nephrologist at R.N. Tagore Hospital, Kolkata, who will guide us through the clinical discussion. Dr. Alok Sharma, Director of Renal Pathology and Electron Microscopy and Head of Research and Development at Dr. Lalpath Lab, New Delhi, who will share his insight on the biopsy interpretation. We'll have Dr. Manish Balwani, is the Honorary Secretary of ISOT, who will contribute to the clinical segment today, and Dr. Radhika Krishna Patil, Vice President of ISOT and Program in charge of CPC, who will discuss the pathological aspect of the case with us. So we look forward to this engaging and insightful session today, and let us begin with the case presentation.
Good evening, respected teachers, my seniors and my colleagues. I am Dr. Anirudh Datta and I will be presenting today's case, a duet of diaquandries from the hepatic crescendo to the fading cadence of the kidney. To begin with, our patient, a 49-year-old male who was hypertensive for 25 years, had a history of ITP in 2003, which was at that time treated with prednisolone, and was hypothyroid for approximate duration of around 6 to 7 years. He was diagnosed with chronic liver disease in 2013 when he presented with ascites. He was extensively from 2013 managed conservatively. He required a couple of sessions of variceal ligations for the bleeding esophageal varices. Now in 2021, he underwent TIPS. In 2022, he had to undergo a revision of that particular TIPS because of his ascites kept building up. In 2023 early part, he developed hydrothorax, which was recurrent and almost persistent. And after that, the ascites problem continued to plagiarize him. In that period only, he also developed an episode of acute kidney injury when his creatinine went up to 2.8. The attributable causes were given as diuretics or probably concurrent left-sided left lower limb cellulitis. And at that point of time, he was managed with IV albumin and antibiotics. Now, for these conditions, he was advised to undergo liver transplantation, and in 2023, he underwent a living donor liver transplantation, donor being the wife, from a A1 to A1 blood group transplantation. He underwent an orthotopic liver transplant with an explant hepatectomy. His MELD score at the time of transplantation was around 13. His graft was a right lobe graft without the middle hepatic vein with a weight of 644 grams with a single bile duct. And at the time of his transplantation, evaluations were suggestive of that he was having pancytopenia, which was again managed with blood transfusions, and his creatinine at that point of time was 1.42. His urine routine incidentally actually showed presence of albuminuria of 2+ at that point of time. Now his operative parameters were that the right hepatic vein was again anastomosed with the right hepatic vein orifice, portal vein was anastomosed with main portal vein, hepatic artery with the segment 4 artery, and the hepatic duct was anastomosed with the common hepatic duct. His intraoperative ultrasound findings were also on the normal limits. His immune suppression therapy, which was started, he was initiated on tacrolimus 0.5 mg twice a day from the day 0, and from day 0 to day 5 he received intravenous methylprednisolone, after which he was continued on oral prednisolone, and MMF was started on day 5 at 500 mg twice a day dose. His post-operative period was overall uneventful. At the time of surgery, he was an ICD insertion was done to ensure the hydrothorax remained under control, which was removed by day 12. He complained of, or he developed at a persistent drain output, and subsequently by day 11 to 18, the drain output actually reduced, and the left and the right abdominal drains were consecutively removed by day 11 and day 18. And he was finally discharged on post-operative day 21, at which point of time his blood parameters, his hemoglobin had improved, his serum creatinine had gone up slightly to 1.57, and his other liver parameters and the INR were in control. However, from looking at the pre-operative values of PCR and serum creatinine, and on subsequent follow-up, actually there was consecutive rise in the serum creatinine as well as the urine in the proteinuria, that is the urine PCR. And from post-operative day, post-operative 1 month, and in each follow-up, there was subsequent rise in the serum creatinine, which gradually kept on rising along with the proteinuria, which did not absolve even after adding on antiproteinurics like telmisartan. So by the time of around post-operative 12 months, his serum creatinine, 12 to 14 months, his serum creatinine had gone up significantly up to 7, and he was persistently having nephrotic range proteinuria. And he presented to us at post-operative month 15 when his serum creatinine was 14.8 and his urine PCR was around 12,000. So during his entire post-operative course, his whole blood TAC levels remained well within control. His hematological parameters, even in the initial months, he had a tendency of bicytopenia with anemia and thrombocytopenia, and overall his tendency to have anemia persisted, and he maintained to have a platelet on a lower side, which at the time when he presented to us was lower than 1 lakh, was at 54,000, and the hemoglobin was pretty low at 6.1. So during this period, the workups which were done for his evaluation to rule out why this renal dysfunction was happening did not reveal to many significant things, apart from the fact that there was a nephrotic range proteinuria in the urine. The urine had 5 to 7 RBCs. His albumin levels were preserved, and his USG was suggestive of bilateral normal sized kidney with altered echo texture as well as CMD alteration. His 2D echo parameters were again within normal limits. Immunological evaluations did not reveal any significant findings, as because he had undergone a solid organ transplantation and was on triple immunosuppressant. We evaluated for a possible BKV also in the patient, which was negative. So the patient with those parameters of around serum creatinine of around 14, with a urine output which had gone down from a 1.5 to 2 liters initially, which had gone down to 800 to 900 ml per day, he was initiated on hemodialysis and he was advised to undergo a renal biopsy. So to summarize, our case is of a patient of a orthotopic living donor renal hepatic transplantation who underwent a progressively worsening renal dysfunction with nephrotic range proteinuria, pancytopenia, and in whom the immunological workup was completely negative. After this, our subsequent sections will be discussed after our discussion regarding the biopsy findings and all.
So, We heard this is an interesting case of this is a renal dysfunction after this liver transplantation. So this is an upcoming topic because we are getting more and more renal dysfunction patients following liver transplantation as the number of liver transplantation has gone up, and many of the patients are coming to us also. So for the clinical discussion, I need to share the screen.
Yes, sir.
Okay. So this is a pure case of renal dysfunction after a liver transplantation that we got at the end of 1 year. Unfortunately, by that time, a significant amount of renal function was lost. So, as you know, this liver failure is a common problem nowadays worldwide, and we do the liver transplantation as a solution of the patients either in cirrhosis or in acute and chronic liver failure or in fulminant liver failure or hepatocellular carcinoma. And cirrhosis being the commonest cause in the Western world, as also in the India, there are several causes, particularly infection-associated liver disease. We do the transplantation. In our case, this is a patient who was diagnosed with cryptogenic cirrhosis at that time. Now we know there are so many etiologies are there. And as the numbers are increasing and more conversion from compensated to decompensated liver cirrhosis, the number of liver transplantation is going up worldwide. So also the complications. So although the short-term mortality that has been reduced because of the increased intraoperative care, improved surgical skills, treatment for the rejections, immunosuppressive agent, the immediate outcome is good. So also as like the kidney, but the long-term mortality has not been reduced. Rather, it is increased over the last few years. It is mostly related to the pre-existing or subsequent metabolic syndrome related to diabetes, due to cardiovascular diseases, the malignancies, as well as the renal dysfunction being one of the important cause of this renal important cause of death of such patient in the long term. As you see in the different studies in the world has shown that the cumulative incidence of this CKD is significantly higher. And this is in the first consensus conference of the Liver Transplantation Society shows that the prevalence may be at the tune of 30 to 90%. At the terminal CKD, maybe 2 to 5% per year. Patients per year, they may require RRT. And studies have also shown that is a 40% patient already in the CKD stage 3 in the post-liver transplantation beyond 4 months. And if you take the 30 ml, the GFR, the prognosis may be very worse. And surprisingly, at 25 years post-transplantation, only 18% has a normal renal functions. So renal failure considers to be 60% of the deaths of the patients in the post-transplantation period beyond 6 months. So renal failure is an important cause. So it needs discussion and much more discussion amongst us and inter-specialty communications. If we go to what are maybe the causes that according to literature, it depends on the pre-transplantation existing events, maybe some peri-operative events as Dr. Aniruddha has described nicely, and some factors for the post-transplantation. The patient who has gotten pre-transplantations, infections, nephrotoxic drug, repeated episodes of hepatorenal syndrome, which has recovered partially or not recovered at all, the high MEL score that has been persistently included the creatinine value, and the development of metabolic syndromes, or maybe pre-existing CKD in such patients, B, C related diseases, B and C related immunological or glomerular diseases, and alcohol. If these pre-existing factors are there and that is noticed or unnoticed, that may be an important cause of the renal dysfunction in the post-transplantation period. Perioperatively, if there is a hemodynamic instability or a reperfusion injury, particularly for the diseased donors, and use of the nephrotoxic drugs, That may be a cause of this renal dysfunction in the postoperative. In our case, there was no hemodynamic instability. There's a living donor, so reperfusion injury was not there, but there was a prolonged drain and surgical period was prolonged. And after transplantations, there are some factors which evolve which doesn't exist in the pre-transplantation period, like use of the calcineurin inhibitor, particularly tacrolimus used in this case, and the level, if not monitored properly, it is a potentially nephrotoxic agent, especially in presence of a liver failure. As well as these patients, many of them has a NASH and diabetic metabolic syndrome. So diabetic nephropathy that develops an important cause of the renal failure with proteinuria, as well as the hypertension. Our patient was hypertensive, so there may be a possibility of development of hypertension associated kidney diseases. If you go this how it happens, if within a year, most of the cases and histopathological findings showed that it was related to reversible CNI toxicities. It may be a diabetic nephropathy, or interestingly, in some cases, a thrombotic microangiopathy. UNOS database evaluated around 1,700 patients, and they have shown that there is a important factor for the development of the CKD following transplantations is a non-recovery of the renal function at 1 month post-transplantation period. Those patients who has not developed renal function, this patient has a creatinine value of 1.47 or 42 at the time of the discharge, and there is a pretty there is a possibility of developing CKD subsequently in these patients. And if you go beyond 1 year, that means the CNI remains the main cause of the nephrotoxicity in such patients. If the CNI has been given in a higher dosage, higher levels, longer periods, they cause about interstitial fibrosis, band fibrosis, whatever we know in the transplant that happens to be here only, involving different mechanisms of intrarenal vasoconstrictory mechanisms. And in a study of 45 patients, showed that CNI toxicity is responsible beyond 1 year of kidney dysfunction in a liver transplant patient is a CNI toxicity. And other causes may be a focal segmental sclerosis in 11%, maybe a non-recovered HERS in around 6.66%, and other causes acute tubular injury or a treatment with the amphotericin for the fungal infections. These are, and in the longer term, diabetes mellitus and hypertension is an important causes. So there may be an pre-existing causes, as I have already discussed, maybe a metabolic syndrome, maybe an HRS, or maybe an creatinine value, and MEL score has increased the incidence of development of this because the creatinine value has been included consistently. Or the problem is that the diagnosis of AKI or CKD may be sometimes difficult. Some data has shown that yes, this is a rise of creatinine beyond 50% or loss of GFR less than 60, or there may be acute and chronic kidney disease. Definition is slightly different that we should know as a nephrologist if we see such patients having a liver transplantations. If the pre-existing factors are not there, we should inquire whether there is any possibility of having AKI in such patients, maybe related to infections, maybe related to toxins, drugs, maybe related to the donor's factors, and mostly ATN that can develop in the perioperative period due to hypotension, recurrent blood transfusions, and use of the nephrotoxic agents. And if it is there, it includes significant mortality. The patient of AKI versus non-AKI in a liver transplant immediate post-operative period has a different outcome at all. Their chance of development of CKD and death is much higher. And if the patient has a liver transplant and a CKD, chances of cardiovascular death also goes up. The patient lifespan is reduced. You can see these are the factors that is related to the immediate post-transplant AKI cases. And also, I have already discussed the development of the CKD in such patients may be related to glomerular diseases, CNI toxicities, maybe a diabetic nephropathy, and so on. And if pre-existing AKI, this patient has one episode of AKI in the pre-transplant period, and probably that has not recovered fully, and that may be a factor that may be responsible for the development of the CKD in such patients. In these patients in the post-operative period, you see if the GFR is not recovered in the immediate post-transplant period, there is a possibility of development of the CKD. And if we go to the causes of the CKD in a patient around 1 year of the post-transplantation, CNI toxicity being the most important, but a significant number of the patients develop a glomerular diseases like MPGN, IgA nephropathy, diabetic nephropathy, proliferative glomerulonephritis, the crescents, along with a partially recovered ATN. You can see this is a common mechanism by which the CNI acts to produce this CNI toxicity. So clinicians should be very aware to prevent the CNI toxicities in these patients, particularly using an induction agents. Here, no induction agent was used in terms of ATGs or basiliximab, and CNI was used on the very first day, and it was continued throughout the period in spite of the rise in the creatinine, probably because there is a difficulty in using mycophenolate because there is a pancytopenia, and difficulty in everolimus because of the nephrotic proteinuria. So tacrolimus was used from the very beginning and was continued for a longer period. That may be a factor. And also at the same time, strategic use of this mycophenolate and this everolimus may reduce the CNI toxicities. So these are the different, you can see the different drugs as an advantages, although CNI avoidance, CNI free regimens have given a better outcome in terms of the renal failure. So lastly, there is some other causes of renal dysfunction. It is seen that BK virus nephropathy happens to be an immunocompromised patient. It is common in the heart transplantation, lung transplantation, but is very rare in cases of the liver. There are some few case reports are available how the native kidney is lost due to BK virus nephropathy. We have also one patient who has lost his kidney due to native kidney BK virus nephropathy. So this can be this is the patient we presented at the 1 year, and if we see the probable causes that is already been described, that has been depicted here. And if these patients have an AKI or a CKD, they have a significant higher mortality. Just I'm not going into the detail, just to summarize, if the pre-transplant factor is there, there is a chance of development of CKD. This patient has an episode of HRS or AKI in the pre-transplantation period, has an infection in the pre-transplantation period, hypertension in the period, and high MELD in the pre-transplantation period. This patient has no hemodynamic instability, but there was maybe an acute CNI toxicities, and there is a prolonged surgical course. In the late post-transplantation period, CNI has not been reduced for a longer period of time, and hypertension continued. And the perioperative period, I have already told that. So to avoid this post-transplant liver transplant renal failure, the strategies may be given by using an induction agent, optimal use of the CNIs by monitoring the level and early withdrawal, long-term strategies wherever is using CNIs, strategic use of the everolimus or the mycophenolate is an important factor, and patient who develop ESRD post-renal replacement therapy should be adjusted, and renal transplantation timing should be taken at the point. So this patient who has a progressive renal dysfunction with a nephrotic range proteinuria at 1 year, and there may possibility this patient probably has a glomerular disease because these CNI toxicities do not produce a proteinuria. So and there is no history of diabetes in these cases. So this can be a focal segmental glomerulosclerosis as far as data goes. It can be a membranoproliferative disease. It can be an IgA nephropathy with proteinuria due to mesangial sclerosis, or it can be a TMA which has developed a chronic course and produce a proteinuria. So so far I have read or I have analyzed the case. My probable diagnosis are these 4, and subsequently the pathology team will tell us regarding the final diagnosis and how to read such patients' biopsy. Kidney biopsy in a liver transplantation patient probably slightly different from that of a native kidney biopsy of a glomerular or a native kidney diseases. So next, hand over to moderator sir to take the further course of these diseases. Screen. Stop sharing. Video ta band karo. Video hita.
So can the screen sharing be stopped?
Video.
Hope the screen is visible.
It's visible.
Good evening, everyone. Thank you, ISOT, for this opportunity. Thank you, Pratik Das sir, for providing the references. I'll be discussing on kidney biopsy in liver transplant patient. So how to read a kidney biopsy in liver transplant patient? We'll first go through some references. So here are a few references. This is from Jin et al. That renal histopathological lesions after liver transplantation. What can we find beside calcineurin inhibitor induced nephrotoxicity? Besides CNI toxicity, so it is 2.5 years study with the 14 liver transplant patients were referred for kidney biopsies, and FSGS was the commonest entity found amongst these 14, then followed by diabetic glomerulopathy, MPGN, and IgA nephropathy. Other study from Lee et al. It is over 13 years duration. Out of 544, 10 were the renal biopsies, and IgA nephropathy was the commonest. So in these two studies, there was no CNI toxicity was the commonest thing, but in this Queen Mary Hospital, Hong Kong, CNI toxicity, which was specifically for IFTA and arteriolar hyalinosis, was seen in 9 patients and followed by diabetic nephropathy, IgA nephropathy. One more study was showing over a period of 13 years, 54 renal biopsies. Most common was CNI toxicity, followed by hypertensive changes, MPGN, IgA nephropathy, diabetic nephropathy. They found crescentic GN also, and acute tubular injury. So now coming to our kidney biopsy, when we see, first thing we should look for the glomerular changes. So let us look for the CNI toxicity changes like TMA. First, we'll have a look at the normal glomerular structure. So this is a normal glomerulus. This is PAS stained section showing a normal glomerulus. Bound by glomerulus is tuft of capillaries bound by this mesangium, and this is Bowman capsule. Mesangial cells are seen. More than 2 cells, mesangial widening. More than 3 cells, mesangial hypercellularity. These are the capillary lumina which are patent. There is no endocapillary hypercellularity normally, and this is extracapillary space or Bowman space. These are the proximal tubules which are showing tall columnar cells and brush border, less tubular lumina. These are distal convoluted tubules showing the low cuboidal epithelium and more tubular lumina, no brush border. Glomerular basement membrane is seen. So now coming to TMA, what we have to see is there any presence of segmental or global mesangiolysis? Then these plump endothelial cells are seen along with subendothelial widening and GBM duplication in cases of chronic TMA. Also, thrombotic, the name suggests are there any fibrin thrombi in the capillary lumina or in the hilar arteriole? These are the fibrin thrombi, fusionophilic, reddish, granular, fibrillar in appearance, seen on the Meson trichrome stain. This is another H&E stain section showing hilar arteriolar fibrin thrombus. This is not hyaline. Hyaline is smooth and glassy. We'll see further. And this is Meson trichrome showing fusionophilic fibrin thrombus. There is some mesangiolysis also seen. So now coming to segmental lesions. So like segmental glomerulosclerosis, collapsing glomerulopathy, it can be segmental or global collapse of the tuft with prominence of overlying podocytes, that is hypertrophy and hyperplasia of overlying podocytes. These podocytes are polygonal in shape along with presence of protein resorption droplets. So this gives a crumpled paper appearance. So this is collapsing glomerulopathy. It is present, we have to look for, and it has to be differentiated from cellular crescents. The cells in the crescent, they are spindle shaped and showing the intercellular matrix, better seen on this silver stain, and there may be breach in the Bowman capsule in the crescents and tubular microcyst, that is dilatation of the tubules with flatter lining epithelium and proteinaceous cast are seen more often in collapsing lesions rather than in crescents. Another entity, that is FSGS not otherwise specified NOS variant, can also be seen. This is a segment of sclerosis showing mesangial matrix expansion, obliterating the capillary lumina. Here the capillary lumina are patent, here we cannot see them, and occasional segmental endocapillary foam cells with overlying this capping of podocytes. This can also be seen. So other thing we have to see now to GBM changes, glomerular basement membrane changes. Is there any thickening? So diabetic glomerulopathy or diabetic nephropathy can also be seen, where there is prominent mesangial widening and these exudative fibrin cap type lesions are seen. There is basement membrane thickening, and again there is prominent PS positive mesangial widening. This is exudative hyalinosis lesions, fibrin cap. And look at this arteriole. This is afferent arteriole. This is efferent arteriole, and both are showing hyalinosis, and intimal layer is involved, not the medial. This is a medial smooth muscle cell, the nucleus. This is not involved. In cases of CNI toxicity, the medial smooth muscle cell, they show the hyalinosis, but in cases of diabetic and hypertensive nephropathy, intimal hyalinosis is seen. So this is another exudative hyalinosis lesion characteristic of diabetic nephropathy. Not every time we'll get to see the KW lesions, but this is capsular drop seen along the Bowman capsule. So this is classic class 3 nodular glomerulosclerosis, nodular diabetic nephropathy, and these are there is prominent PS positive and silver positive mesangial widening focally exceeding the diameter of adjacent capillary lumina and forming this irregular sized acellular Kimmelstein-Wilson lesions. These are the KW lesions and showing the linear IgG deposits along the capillary lumina on IF study. So other basement membrane thickening we have seen. Now basement membrane duplication is there or not, that we have to see. This is MPGN pattern, which few of the studies they also noticed. These glomeruli are enlarged and hypercellular when they are more than 2.5 times of the proximal tubule size. They are enlarged, or they are not fitting under your high power 40x lens. They are exceeding the 40x lens or the high power lens under the microscope, then that we call them an enlarged. Hypercellular, so giving the appearance, club-shaped appearance, accentuated lobulation is seen, lobular accentuation is seen, and there is GBM duplication showing the tram track appearance and mesangial cell interposition. So this MPGN pattern is also seen. Other thing now, thickening, duplication, or any subepithelial spikes. Yes, this is a silver stain, Jones-Smith-Hanamine silver stain, showing this subepithelial spikes on this oil immersion lens. This is 100x, which can be seen on the 40x also. So this is a case of membranous nephropathy, and when they are cut tangentially, they are seen as non-argyropheric or silver negative, these pinholes or craters. This is poor man's EM, that is mesentrichrome, in which this pushinophilic, that is reddish subepithelial deposits are seen of membranous nephropathy. So now coming to cellularity, we have seen the capillary lumina, the changes, segmental changes, then we have seen the basement membrane changes, glomerular basement membrane changes. Now coming to cellularity. So is there any mesangial hypercellularity? Yes, here it is mesangial hypercellularity is seen more than 3 cells, and on IF study, mesangial coarse granular IgA deposits are seen, confirming it as the IgA nephropathy. Other rare entity which the few of the studies mentioned were cellular crescentic GN. So these are the cellular crescents. Now coming to tubules, in the tubules, what we should look for, these are the isometric vacuolizations. Proximal tubules are showing isometric vacuolization in the cytoplasm of these tubular epithelial cells. These are seen in CNI toxicity. Also look for any tubular luminal calcification for CNI toxicity changes. And interstitium, normally there is no interstitium seen in between the tubules, but when the interstitial interstitial fibrosis is seen when the tubules are atrophied here, and this is classic striped fibrosis. Striped fibrosis, that is alternate bands of fibrosis are seen. These are the non-atrophic tubules with loss of the brush border showing mild tubular injury, and these are the atrophic tubules showing they are reduced in size and showing wrinkling and thickening of this tubular basement membranes, and there is interstitial fibrosis with inflammation. So this was striped fibrosis seen in CNI toxicity. In the vessels, CNI arteriolopathy changes are seen. Those are arteriolar, these medial smooth muscle vacuolizations in the arterioles. In this picture also we can appreciate this medial smooth muscle vacuolizations, this ballooning of this medial smooth muscle medial smooth muscle cells. So this medial smooth muscle ballooning, it is known as CNI arteriolopathy. And CNI, this the small interlobular artery which is showing this medial smooth muscle cells, they are involved in hyalinosis, not the intima, but here also the media is involved. That's what is seen in CNI toxicity. So this is giving a nodular appearance. So there is media is involved, not the intima like in diabetic hyalinosis. Thank you.
Thank you, madam. So now we can have discussion on the slides by Dr. Alok Sharma.
Yeah, thank you. Thank you, ISOT leadership, for having me here for this case. Is the screen visible, sir?
Yes, sir.
Yes, you.
Okay, thank you. So this biopsy was received. I think we already have a good background on what the changes look like, various types. Maybe it will be easier to interpret the biopsy in this slide. So this is a very low power view, as you can see. And as Professor Das had initially told in his, by the time the biopsy was done, I think it was quite some time had elapsed. And this is exactly what you see in this biopsy. You can see a lot of tubular atrophy and interstitial fibrosis. You can, wherever my pointer is going now, are the only few areas where you have viable tubules. Most of it has undergone a lot of atrophy and fibrosis. And even at this power, you can see one sclerosed, a couple of sclerosed glomeruli here. And this is an artery. We'll come to that at a higher power later on. So we can see that already a lot of chronicity has set in. When you go a little higher onto the biopsy, you can see there are more features here. There is one glomerulus in which the tuft has kind of shrunken, right? You can see it. I think you heard Dr. Radhika talk about that thing, but the hypercellularity which you are kind of seeing here is not true hypercellularity, in the sense you are seeing more cells crowded together because of the shrinkage of the tuft. So there is a discrepancy in between the sclerosis and the cells dying out. So that's why you're seeing this. Anyway, you can barely see any viable capillary lumina there. And this is another glomerulus which has undergone sclerosis. Now, I think you heard about that pattern, ischemic pattern of fibrosis, which is that so-called striped fibrosis. So that striped fibrosis is basically because it is a pattern in which the deeper cortical tubules, which have got less supply, they get atrophied earlier than the proximal tubules. So once they are seen adjacent to each other in a two-dimensional view, you feel as if one set of tubules has atrophy and got fibrosis earlier than the other one. So that gives a kind of a striped pattern, alternate bands. So even here, if you look carefully, what you see here, where my pointer is right now, it's an atrophic area. And this particular type of atrophy is called as an endocrine atrophy. So pathologists understand that whenever there is an endocrine pattern of injury, these are small tubules which are getting atrophied and not much of fibrosis. There is fibrosis, but it is disproportionately less to the degree of atrophy. So this is typical of an ischemic pattern of fibrosis. Similar in the other areas, you can see this band, which is relatively normal. And on both sides of this, you can see nice atrophy. This is another glomerulus, which is showing areas of sclerosis and wrinkling. And a lot of glomerular changes will come to that in a while. This was the artery we saw at the low power magnification. And you can see a lot of subintimal sclerosis, maybe some edema, but a lot of sclerosis and thickening of the arterial wall. Other places, you actually had a couple of tubular cysts. You can see these cysts. And I put these images side by side to show you that there are a few refractile oxidate crystals as well. So maybe it's a part of the acute tubular injury which had superimposed. So there are some oxalate crystals also as a part of the tubular injury here. Now coming to the glomeruli, we'd seen about the ischemic alteration. So this particular glomerulus, if you look carefully, it is shrunken, it is smaller, and you can barely see any viable capillaries, but the ones you can actually see are showing a lot of wrinkling and reduplication, if you can look at in the silver stain. So this again tells you that the blood supply of the glomerulus has been compromised and it is kind of going ischemic kind of a damage. And the other one, you can see a globally sclerosed glomerulus here. Another glomerulus, so this is a PA stain, and you can nicely see the Bauman's capsule and similar appearance to what we saw in the last glomerulus. It is much better seen here. You can see it's kind of a mesangiolisis kind of an appearance, and which has become more chronic than acute. So once that chronicity sets in, you can see those thickened appearing capillaries, mesangiolisis, fraying of the mesangium. It gives kind of an ischemic or wrinkled kind of a look. Now coming to the vessels, so we know that the culprit are the vessels. Because of the vascular damage, the glomeruli are showing secondary ischemic changes. So you look carefully, you will find. So this is an arteriole which has actually been occluded by a thrombus. So this thrombus is kind of slightly oldish. It has started reorganizing itself. It's not that acute fibrin kind of a thrombus, but it is something which has partly reorganized. And even in this is another transverse section probably of the same arteriole. You can see some fibrin possibly accumulating in the lumen of the arteriole. Now, this is a slightly larger arteriole on a transverse section. What you're seeing here, these areas are areas of calcification. So we see there has been a chronic kind of a vasculopathy which has set in into this kidney. So these slightly bluish granular areas are areas of subintimal calcification. Now, these two images will show you. So one on the left side, you can see this glomerulus. And when you come to the right side, you can see, so this is an hilar arteriole. Here you can actually see an active thrombotic microangiopathy occurring. So the reddish structures which you see, this part are fibrin, and whatever the RBCs are traversing through it are actually undergoing microangiopathy. They're getting fragmented. That's why the name of that particular entity. Another area, so this again is a Messens trichrome stain, and you can nicely see some RBCs which are actually traversing through it and getting fragmented. So this is a microangiopathy. So it's very clear here that there is a lot of endothelial injury because of which you can see these vascular alterations. And secondary to that, you are seeing a lot of ischemic glomerular alterations. And over a period of time, there has been a lot of atrophy and fibrosis which has set into this kidney. So just to summarize what we saw in this particular biopsy, we saw a lot of ischemic glomerular alterations, we give GBM remodeling, and a lot of secondary and global segmental sclerosis. So all these are patterns. See, FSGS is not a disease. All the renal pathology is all about patterns, and same pattern can be seen in multiple etiologies. So that's this very important part of the overall diagnostic approach to renal biopsies. And we saw the significant increase in IFTA. I showed you the endocrine type of tubular atrophy and interstitial fibrosis, maybe some hint of a striped, if you want to call it striped kind of fibrosis. It was very much there. We saw some tubular cysts, oxalate crystal. They're all signs of secondary tubular injury. Prominent vasculopathic changes in form of hyalinosis, calcific concretions, and we also had an evidence of thrombotic microangiopathy, which kind of was more of subacute or chronic in nature. And we did the immunofluorescence, which was negative. So overall picture is that of a subacute to chronic thrombotic microangiopathy with significant increase in interstitial fibrosis and tubular atrophy and secondary renal parenchymal changes. Thank you.
Thank you, sir. So now let's have the second part of the case by Dr. Aniruddha. I think in between, if we can have a few questions from the audience, these are there. So should we take that or okay? I think we are can start.
Sorry for the technical glitch. So I'll be coming to the second part of the case. So the biopsy reporting was of that of a suggestive of a thrombotic microangiopathy, and for which we started the patient on plasmapheresis. The patient was initiated and was continued on plasmapheresis for 7 sessions with 1.5 times of the replacement volume, and we replaced it entirely with fresh frozen plasma. And at present, the patient's present status was that of no renal recovery. The patient remained hemodialysis dependent even after 7 sessions of plasmapheresis, and his blood parameters showed that the hemoglobin remained low, the creatinine remained high at around 7.8, and he had a urine output of around 400 to 500 ml per day. So the fistula was created, and in his immune suppression, what we modified that we the graft function had remained stable all throughout this entire STOMI course. We stopped the tacrolimus in view of the renal dysfunction and the finding of TMA, whether it had any contributory role towards it. But even after withdrawal of tacrolimus, there was no improvement in the renal parameters. So coming to the diagnostic algorithm of a possible atypical hemolytic uremic syndrome or a TMA, whenever we are faced with a diagnosis of TMA, we are supposed to work it out and to find out whether there are what could be the possible attributable causes, and the findings. Once you exclude out TTP, it mainly depends on the genetic testing and evaluation of the expression of the antibodies. So for this patient, we actually did the genetic evaluation. We did a whole exome sequencing for the phenotype of TMA, and we also did a link MLPA, multiple linear probe assay to look at the duplication and deletions of the complement factor H related proteins. And in the whole exome sequencing, incidentally, we found that he had a pathogenic mutation of ATP7B, which leads to Wilson. However, his evaluations prior to the transplant had shown normal ceruloplasmin and copper levels. And when we looked at the MLPA reports, it was positive for deletion of the CFHR1 as well as CFHR3. So if we look at the factor that the patient currently is hemodialysis dependent and he wants to undergo a kidney transplant, so we need to answer regarding the feasibility. So when we try to stratify it, we see the complement factor H related protein 1 and 1 to 5 mutations come under the category of high risk for recurrence of atypical hemolytic uremic syndromes or TMS, and that mandates prophylactic eculizumab therapy whenever we are considering the patient for a renal transplant. And the second most important factor here would be the donor, as the liver was donated by his wife, and for a patient in whom a genetic mutation which might be causing a TMA is found in them, getting a living related kidney transplant or a living related donor may be a bit complicated. Mutational analysis are necessary, and even in patients in whom we don't identify any known mutations, still it has to be counseled about the possibility of risk, because unidentified mutations which are not in the library can always be present. So for them, disease donation or living unrelated kidney transplants may be a option. And whenever we are considering the use of eculizumab in these kind of patients, prophylactic use rather than use of eculizumab as a rescue therapy is always preferred, because these trials, multiple trials, and including this one, had shown that use of eculizumab prior to the transplant actually resulted in a much better median EGFR from 6 months from the transplant, compared to whenever we use it as a rescue therapy or when we used it when we diagnosed TMA after transplant. So in our case, the main issues which remained was the feasibility of the kidney transplantation, whether and what would be exactly the role of eculizumab, as this TMA was triggered after the living donor liver transplant, whether the wife needs to be evaluated for mutations as well, and for him, who could be an ideal donor. With this, I would like to conclude my presentation and would request the moderator, sir, for continuing the course.
So today we had a very good discussion related to post liver transplant, how the renal failure happened and how the further evaluation was done. So now let's have how the atypical HUS workup before transplantation and after transplantation to be done in the patient. Let's have insight from Dr. Manish Balwani.
Thank you, Dr. Jiga. So it was a wonderful case, and we saw the post-liver transplant TMA leading to CKD stage 5, and the patient is now on dialysis. So it was briefly touched upon.
So can we have the slideshow?
Yeah. So can you see my screen?
Yes, sir. Screen is visible,
Yes, we can.
Yeah, screen is visible, right?
but it's
So
not slideshow.
yeah.
Perfect, sir.
Yeah, thank you. So Dr. Anirudh just briefed upon this. So patients should be evaluated from the serum and plasma with complement levels C3, C4. Usually we find the low C3 levels, and we should see for the antibodies to the factor H. If flow cytometry is available and the testing is available for factor H, I, and MCP, we should go for it. Autoantibody testing in India is available for factor H and C3 nephritic factor. If possible, we should have the baseline functional assay for CH50, AH50, and RBC hemolytic assay C3b depositions. To rule out sometimes the underlying monoclonal gammopathy, we can do it, especially in case of elderly patients. Apart from this, we should subject these patients to the genetic evaluation. And here we can if we have the some variant which is identified, then we can distinguish on the basis of findings into the benign, pathogenic, and the variant of uncertain significance. So just I will touch upon that the therapeutic plasma exchange, it's beneficial mainly in complement mediated HUS, those who are antibody positive. So the plasma exchange will remove the pathogenic antibodies, mostly anti-factor H antibodies. And of those also, only 30% patients respond to it. Even the response is mostly seen hematological, and the organ and response and the final outcomes in terms of kidney are not very favorable. In such situations, most of the time, the best treatment is with the terminal pathway inhibitors, like we have much more experience in the last 15 years with the eculizumab. So eculizumab and nowadays a new molecule ravulizumab have significantly improved the outcome. Now we have many times a question how long to give, how much to give, whom to give, whether it will relapse after the stopping the treatment. So I will briefly touch upon those. So we all know it is an anti-C5 monoclonal antibody. So after the use of eculizumab, the rate of dialysis dependence post-transplant at 1 year has reduced to 10 to 15%. Along with that, the persistent use of recommended dose of eculizumab has led to improvement in hematological parameters in almost 88% of patients in post-transplant, and the mean increase of GFR has been seen up to 32 ml per minute after 26 weeks of treatment. The significant improvement in GFR has been observed even after 26 and 62 weeks. So this therapy should be considered in any patient whenever there is suspicion of complement-mediated HUS. If you have ruled out all other secondary causes, the treatment should not be delayed till you have the genetic reports. So we should start the treatment as early as possible, as Dr. Anirudh said, even just at the time of transplant. We should not wait for any kind of relapse recurrence. The optimum duration still remains unclear, but it has been seen that around 50% will relapse if the eculizumab is stopped. The strongest predictor has been the presence of complement genetic variants. And of those genetic variants, most of the patients have around 70% have factor H mutations and 50% have MCP mutation. So in patients who you have the normal complement genetic analysis, in those it can be thought that this eculizumab can be stopped. About newer drug, ravulizumab is again a long-acting C5 inhibitor. The only advantage remains the less frequent infusions. Newer molecules like anti-C3, pegcetacoplan, iptacopan, which is anti-factor B, and danicopan, which is anti-factor D. As the main etiology lies in the liver, it has been earlier postulated to have the combined liver-kidney transplant, but nowadays with the effective anti-complement therapy, it is not being pursued. So I will just briefly touch upon experience of last 7 years. So here in our data, we have the mostly patients who have the anti-factor H antibody high levels more than 100. The lab upper limit was 90, and those were also genetic mutations were positive. So around 293 patients were tested. Of those, 131 of those anti-factor H antibody was positive in 59, and the complement mediated genetic mutations were positive in 86. So these are the types of mutation. I will just highlight here. The most common mutation present was CFH-R1 and R3. In those genetic mutations, 86 positive, AFH level was high in 23. In 50, the AFH levels were low. Now, kidney transplant were performed in 37 patients out of these patients. So in those 37 patients, we had the pre-transplant diagnosis in 33, and post-transplant we came to know after the transplant in 4 patients. The post-transplant recurrence was seen in 7 patients. These were the other complications. In these post-transplant patients, the underlying genetic mutation, again, the most common was CFH-R1, R3. This was the post-transplant and pre-transplant treatment protocol. Of these 7 patients, we had the 1 patient who suffered graft loss. This patient was post-COVID mucormycosis, and after 1 year, he was posted for renal transplant, and immediate post-transplant in a week, he had recurrence. As he had the history of mucormycosis, we did not chase this patient with further treatment except for the plain plasma exchange. And we noticed that this patient had the graft loss. Rest in other patients, because all of these were the antibody anti-factor H positive and were unaffordable for the eculizumab. So these patients were treated with the plasma exchange and rituximab. One patient out of the 7 is under the complement inhibitor drug trial therapy. In 30 patients, there was no recurrence. This is the creatinine trend of those 7 patients. And on the other 30 patients, we can see the mean eGFR 1.35, those who had no recurrence, and 2.2 in those 7 patients where we had recurrence. So this is just the summary. In view of shortage of time, I won't go into the much more details. So to conclude, I'll just say that renal transplant should be carefully performed even in the absence of anti-factor H antibody or the presence of CFH and CFHR related genetic mutations. Larger studies are needed to determine the significance of these genetic mutations in unknown CKD patients, CKD with unknown etiology patients. Thank you.
Thank you, Dr. Manish Palwani. You have given very good insight and how in Indian setup this workup and further treatment affected the transplant that was really good. So now, Pratik sir, Dr. Pratik sir, from your side, any comment?
We got this case and we have done much. We don't have much experience on this atypical HUS and transplantation. So my question to this, whether we go ahead with the renal, because they are very keen to renal transplantations. Whether we go ahead now, the eculizumab will be available maybe within a month or so, and with a reasonable, much cheaper compared to the international brand. So if this is there, we should go ahead with the transplantation or not. And secondly, this patient has a liver transplantation prior, and wife was the donor. And if we can test this wife for this same genetic mutation, if it is absent and wife's liver is there, should we go ahead with the transplantation without eculizumab or not? So because already he had a liver transplantation. And thirdly, if the wife again wishes to donate the kidney to this patient, whether we should accept or not. These are the issues that are available. So if somebody can answer whether we go ahead with the transplantation, eculizumab is mandatory or not, whether liver transplantation will give some benefit to him, whether wife can be the donor.
I think, sir, we should have first, we should exclude all other the secondary causes of TMA. After excluding, as you are almost excluded, then liver transplant ideally should have cured the TMA related to complement genes. So in such situation, definitely, I think the wife should be tested for the underlying genetic complement related evaluation should be there. She should be posted for that. And as soon as we have the reports, then we can further decide the plan of action. And with the recently, we know that AstraZeneca is launching the eculizumab in India, and it may be available in a few months. Till that time, the genetic report can also come, and afterwards, again, we may decide further course of action. Till that time, the patient can be put on dialysis. Ideally, the liver transplant should have cured because this is where the CFH comes from. So common factor H related issues should have been solved. If it is something else, then it is again, it will be clear in the genetic analysis. This is even with the limited experience I have, I can say.
I have a huge experience because in this field, everybody has a limited experience because nowadays we'll be probably getting much aware more and more about this atypical HUS because we couldn't think of the disease. Otherwise, Dr. Sharma would have been reported an HUS. We never thought of it can be an HUS because it's a proteinuria in a post-transplant period and any glomerular disease and that would have been the possibility. But we got this report. Now we have tested, got the mutation positive. So, how commonly you get this liver renal failure or renal dysfunction following liver transplantation? Because, and also in the pathology, Dr. Sharma, Dr. Patil is there. How commonly you get a biopsy from such patients, a native kidney biopsy from a liver transplant patient?
So we've seen quite a few. I've been doing renal biopsies for a very long time. Maybe we've seen close to 100 of them. But as I think if we had and we did a small analysis long time back, that time also we had thrombotic microangiopathy as a important sign feature in post liver transplant. But many of these are actually ascribed to tacrolimus. So it's difficult. Of course, genetic testing was not done in all, but yes, thrombotic microangiopathy. Whatever I have seen with liver biopsies, whenever kidney biopsy done in a patient or liver transplantation, you often get a diagnosis of thrombotic microangiopathy there.
So can it be the cause that previously when these direct antiviral agents are not available and hepatitis C related liver disease was treated by the interference, they have told the interference may be a cause of this precipitating TMA. So whether this is changed over the years, the previously hepatitis C interferon treated patients, kidney dysfunction, more thrombotic angiopathy, now they're getting more than direct antiviral agents and the incidence has been reduced in the recent times.
Yeah, possibly. I think maybe yes, that if we have seen it over a period of time. It is definitely at least the number of biopsies being done post renal dysfunction for liver transplantation has definitely gone down. I used to see them more maybe 3 or 4 or 5 years back. Definitely, it has become less now.
Okay. So we should wait for some time and till the eculizumab is available and till the patient we can go ahead with the transplantation provided wife workup should be done in the meantime. That is your suggestion. Okay. Okay, over to Dr. Srimali or Dr. Patil to conclude whether such cases can be discussed. Is it truly a clinical pathologic discussion? Is both pathologies has contributed most of the cases. We have the clinicians. Now we have to take over from this one, how to take this patient to a healthy life by doing a proper transplant, renal transplantations with proper immunosuppression.
Yes. There are few questions. Should we take those, Jigar Shrimali sir, or are we running
Yes.
out of time?
So I think there are 4 questions that are already answered by Aniruddha. Okay, there are still 5 questions. The first one is it incidental renal involvement or related to liver transplant? That is the first question.
So both the things are rare because we get TMA in a native kidney. It is not very common disease, and it has always this is an atypical HUS. You get a second hit, and here the liver transplantation has probably acted as a second hit, and probably it is related to liver transplantation because even though we have withdrawn this tacrolimus in such patients, there is not much recovery. Although by this time lots of chronicity has happened. But probably it is related to the liver transplantation. The genetic background is confirmed. Second hit is confirmed. So it is not related to tacrolimus, we think.
Okay. There's a second question is all patients planned for renal transplant with unknown cause of CKD? We have to send genetic panel and anti-factor H antibody level prior to transplantation?
No,
So
Dr.
I
Manish.
will, yeah. So what is my practice if the patient gives history of sudden onset hypertension, and if there is young patient, a sudden history of uncontrolled blood pressure, so and the patient comes to us, so we do evaluate such patients with the complement C3 level, and if prior reports we look in the history, if there is any low hemoglobin along with the low platelets, so we keep such patients with high suspicion, and we do send such patients for the anti-factor H antibody level. Even if the anti-factor H antibody level is not positive, and the clinical suspicion of onset of renal diseases along with the hypertension, we do assess such patients with the genetic analysis because it helps us in understanding whether the patient is prone for the atypical HUS. Even if there is the presence of CFH related or CFH mutations in the genetic study is positive, we certainly go ahead with the renal transplantation, assuming 20 to 40% of such patients can have such normal public can have such genetic mutations presence. But beforehand, we do have idea if such patients do relapse, then we have the treatment with us available. So I have such few patients where the AFH level was low, normal. C3 level is normal at the time of consultation to a practice in our practice, and the genetic studies are showing the mutation. And the post-transplant, around four such patients had in the first week the atypical HUS TMA recurrence, which is biopsy proven along with the biochemical parameters, and we initiated such patients with the plasma exchange. And in view of unaffordability, with these patients we are given the rituximab also. So this helps. If it's affordable, you should go for it, in my view. With the certain history of
So,
most of the TMS will come to you with hypertension or will give the history of hypertension. So clinical history is equally important, and we should check the prior records also.
so Dr. Balwani's suggestion or secretary's suggestion is that you should keep a slightly lower threshold nowadays to send this kind of testing, particularly if there is an episodes of hypertensive emergencies, is a family history positive in a postpartum situation, that we should send more and more. And and you have already told there should be a deletion that is a normal part of the genetic pattern. This is a UK study which shows that is a 24% of the Gujarati population, they have a normal deletion. This is that is natural. That should not be considered as a mutation.
Yeah, that should not prohibit us for going ahead with the transplantation.
Yes, yes. Nice.
Okay, the question is, I think, by Dr. Ranjan Sahu. The comment is, I think, doing functional assay in the patient will resolve our doubt, but it's not available in India. So, any comment on the availability on India?
Yes, yes. It will be available. They have already launched, everything has been cleared. They have started, GCI permission has been taken.
I think that they are asking for the functional assay.
Functional assay.
Oh, acha.
H. Common factor H level, few people are, one of the lab I know, they are doing common factor H level, but the all other functional assays is still is not unavailable in the India.
They have told in the book is a level of eculizumab. There's a trough level of eculizumab. So are you aware, or it is beneficial, or
In India, sir, we are yet to have the equilibrium.
the trough level like that? Then we can ask the company to do this level free of cost.
Yes.
So now the role of eculizumab in genetic atypical HUS, till what duration it is to be given?
I think I addressed it. So eculizumab has a definite role in genetic HUS, and the duration, as I said, it's not very clear. But in those patients who have the CFH mutation, in studies it has been found around 72% had the relapse when you stop the eculizumab, and in the membrane cofactor protein, around 50% relapsed. So it should be given as long as possible. So that is what the current literature says. And with the new in hand with like iptacopan and other oral molecules which are in showing the good promising results, I think then it will be you will be in a better situation with less costly drugs, more armamentarium.
So there is comment by Dr. Kapil Sejpal. Wouldn't the patient be sensitized to wife if she is considered for the kidney donation?
Pratik sir, should I take this?
Yes.
Yeah. So if there is any history of rejection, then definitely we should evaluate. And even before going at the kidney transplantation, we should evaluate with the sensitization. So, but in biopsy, as there was no evidence of rejection, and I think we can go ahead if the single antigen bead and flow cross match permits.
And another thing is that so far sensitization is concerned in other solid organ transplantation, there is a dilemma whether the kidney back to back, that is a huge sensitizing event, but is a liver followed by kidney transplantation, this may not be, because if you see if there is some indications of not giving an induction, is a patient who is a liver transplant and getting immunosuppression is a stable graft. If you do kidney transplantation, you can do it without induction. So
Yes.
that may not be that sensitized. So we have to test for sensitization. If it's positive, then definitely you have to take the. And this liver graft has been stable throughout. So
Yes,
much
liver graft has no problem.
problem,
You
exactly.
can see it is not showing any signs of rejection. Like what usually it comes in the form of a raised ALT, AST, obstructive jaundice or something like that. So it has been stable. There is no clinical episode of rejection. I think we should evaluate as we usually do.
Dr. Manish, in your review, have you found such a high level of proteinuria? Like in this case, was there 12 gram of proteinuria? In
So
other HUL?
in acute TMA, in acute TMA, definitely you will have the more proteinuria. So it may not be clinically evident in the form like the patient is having patient is full bloated. But if you will see the urine PC ratio, it will be around 10, 12. So I have seen a few pediatric patients where there is recent onset of TMA, a typical HUS, and within a week you see the patient has the UPCR is around 10 or 12, and you do biopsy. This because of the ischemic injury, glomerular collapse. I think there is the proteinuria, but they do well with therapeutic plasma exchange. Identify the cause. If it is antibody positive, then the plasma exchange will help. And to prevent the new formation of AFH level, you can give, if not available eculizumab, you can try the rituximab. So I have a patient who was ventilator dependent and was dialysis dependent for around 10 weeks in 2017, and still he is in follow-up. His AFH level were above the calibration, that is above the 12,000, and pediatric patient at that time his age was 6 years. Now he is around 12 years, and the AFH level still it is high, though not normal, around 200, but his kidney function is normal, KFT is normal, urine albumin is nil, antihypertensive requirement is hardly ramipril 5 mg OD, and he is growing well. So mere presence of AFH level is also not pathogenic. There has to be, as Dr. Pratik Das sir said, a second hit. So you may be genetically predisposed, but there has to be some kind of second hit. And if you are susceptible, then there can be a development of atypical HUS or TMA episode. So for that time,
So
you have to.
with this, when we need second kidney transplantation, what could be the immunosuppression regime?
Usually, what they say when people do combined liver kidney transplant, they say that immunosuppression has to be guided by the liver transplantation, not by the renal transplantation. So in such cases, kidney after liver, I think we need the help of hepatologist, transplant surgeons, liver surgeons, and I am in my individual capacity unable to answer this. We will need a holistic approach along with the team.
So in this case, I was asking in this case.
Yeah, so I have no answer for that, sir. So I think we will need the help of liver transplant surgeons, physicians to understand how we can go ahead in such a.
There is one more question. This patient had CFHR1 and CFHR3 mutation, which can be seen normally in Indian population. Was he tested for anti-CFH antibody? How to differentiate AHUS versus CNI mediated TMA clinically and by biopsy?
Anirudh, you can answer that. Was he tested for common factor H antibody?
Yes, it was done, but it was negative.
AFH antibody, I will take it from here, can be negative in the presence of genetic mutations, and the patient can have the TMA also. So not in every case the AFH antibody will be positive. So mere absence of anti-factor H antibody, you cannot label such patients as no, this patient does not have the TMA. So absence of AFH antibody still, if the clinical picture is fits, like we have the biopsy and all other causes are ruled out and the genetic mutation is positive. So there is a second hit, as Dr. Pratik sir said, and we should be suspicious for TMA in such patients. So anti-factor H alone does not exclude.
Any question? I think most of the questions are dealt. Otherwise, Dr. Radhika Patil, from your end, any questions?
No, sir. I think all are
I think, sir, we have almost overshot.
come to the.
We can close.
So,
So, yeah. Thank
yeah.
you.
So,
Thank you, dear all, respected all, actually, all stalwarts in nephrology, nephropathology, for giving your precious time. Dr. Aniruddha Datta, sir, for giving wonderful explanation and start of this CPC today. Dr. Alok Sharma, sir, for enlightening us again and again. We would love to hear from you the basics. Dr. Pratik Das, sir, thank you for the elaborative class. And Dr. Manish Balwani, sir, our honorary visionary secretary, thank you for your explanation. And Dr. Jigar Shrimali, sir, for coordinating us. And last but not the least, Deepika and Himanshuji and his web team for this coordination. Thank you. Thank you.
Thank you, ma'am.
Thank you.
Thank you very much.
Hope CPC webinar will continue to increase our knowledge base.
And this is our Honorable President, Dr. Arpita Chaudhary, Madam. So thank you, Madam, for being here and guiding us all the way.
All the best, Radhika. The team is doing excellent.
Thank you,
Thank
ma'am.
you.
Under your guidance only. Thank you.
I think
Shall I end the session, sir?